Assalamualaikum and good morning to all the clinical instructors and lecturers. Today I would like to present a case on nutrition management of end-stage renal disease on continuous ambulatory peritoneal dialysis CAPD. I start with the client history. Patient is Mrs. X, 46 years old. For the social history, patient is married and blessed with 2 children, aged 20 years old and 16 years old. And patient worked as a primary school teacher. For the medical history, patient is diagnosed with CKD and started on CAPD 1 month ago. Patient received CAPD regimen, dwell time 4 to 6 hours, 4 cycles per day, and dialysate 2.5% 2 liter per cycle. And patient has underlying systematic lupus erythematosus SLE since patient is 18 years old. SLE is a multi-system disease with potential kidney involvement, and patient was referred to diet clinic for the dietary assessment and intervention. For the anthropometry data, patient weight is 73 kg with height 1.55 meter. Patient BMI is 30.4 kg per meter squared, which is classified as obese class 1 based on WHO 1995. And for the ideal body weight is 53 kg. This is using ideal body weight at BMI 22 kg per meter squared. For the biochemical data, for the renal profile, patient urea and creatinine show higher value compared to the normal range because of the kidney failure. For the lipid profile, triglyceride is normal, but patient total cholesterol, LDL cholesterol is high and HDL cholesterol is low. For the full blood count, patient hemoglobin is low, which is 10. This is acceptable range because based on the CPG CKD 2018, the acceptable range of hemoglobin level for CKD patient is within 10 to 12 gram per deciliter. And for the nutrition-focused physical findings, patient has no pedal edema, has no sign of muscle or fat wasting, patient has full occlusion, but patient has mild paleness. For the food and nutrition history, patient claimed that her appetite was good. Based on the diet recall, patient has 3 main meals and 1 snack in a day with proper meal timing. Based on the diet recall, patient current energy intake is 1200 to 1700 kcal per day. This includes the calories from the dialysate with 60% of carbohydrate, 10% of protein and 30% of fat. And based on the diet recall also, patient has inadequate fiber intake from fruits and vegetables, which is only 2 servings of vegetables and 0 to 1 servings of fruits in a day. And patient frequently consume high sodium food such as sliced cheese and soy sauce gravies. For the medication, patient was prescribed by the doctor with prednisolone 20 mg OD as an anti-inflammatory to treat inflammatory disease such as kidney disease, and patient received amlodipine 5 mg OD to help achieve blood pressure goals and preserve the kidney function. And patient also received IV methoxy polyethylene glycol lipotin beta 60 mcg twice in a week as ESA, which is erythropoiesis stimulating agent, used to increase the synthesis of red blood cell to treat chronic kidney disease anemia. And patient also consumed lovastatin 20 mg ON. This is for the primary and secondary prevention of the cardiovascular events. And in addition, SLE patient also prescribed with statin as an anti-inflammatory and cardiovascular protective effects for the patient with SLE. For the nutrition diagnosis, the suitable nutrition diagnosis for this case is patient has increased nutrient needs related to current condition of ESRD secondary to starting continuous ambulatory peritoneal dialysis, as evidenced by diet recall showing inadequate energy, protein and macronutrients intake compared to the current needs. For the intervention, there are a few goals. First is to prevent further weight gain and unintended weight loss. Second is to maintain adequate energy, protein and nutrients intake. Third is to delay the progression of end-stage renal disease. And fourth is to prevent CKD-related complications, for example, cardiovascular risk and also anemia. And the nutrition prescribed prescription for this patient is approximately 1900 kcal per day of lipid lowering diet, low salt diet. This includes the calories from the dietetic. For the estimated needs for the energy, I use two formula. First, by using quick method, I use 35 kcal per kg body weight because based on the M90 of CKD, 35 kcal per kg body weight is the suitable kilocal that is prescribed for CAPD patient, and I get 1900 kilocal per day. But by using Mifrin, I get lower calorie, which is 1300 kilocal per day. But I choose 1900 kilocal per day based on quick method because it is more suitable for patient on CAPD treatment. And for the weight I use for calculation is 53 kg, which is the ideal body weight at BMI 22 kg per meter squared. For the protein requirement, I use the same weight used for calculation, which is 53, and I use 1.2 to 1.3 gram per kg body weight of protein. I get 63.6 to 68 gram of protein per day. For the carbohydrate and fat, I get 50 to 60% carbohydrate and 25% to 35% fat. For the fluid requirement, patient should drink up to 1500 ml per day of fluid, including the meal and also the water. And for the nutrition intervention, first I would like to educate patient on the lipid lowering diet by advise patient to limit food high in saturated fat, trans fat, cholesterol, and introduce to patient the good fats such as PUFA, MUFA. I will show the patient the food checklist of types of fat, and also suggest patient on healthy cooking method and the tips when she eating out. And secondly, I would like to educate patient on increased protein needs when on CAPD compared to pre-dialysis. And first, to educate on protein sources from animal sources and also from the vegetable sources of protein. And then provide protein portion sizes as per recommendation to patient. And third, I would like to educate patient on the low sodium diet. Advise patient to avoid or limit the high sodium foods such as the sliced cheese that she usually consumes, the processed food, the soy sauce, the condiments, and educate on tips of reducing sodium when patient eating out. And next, I would like to advise patient to increase fruits and vegetables intake in a day. At least 3 servings of vegetables and 2 servings of fruits in a day based on the healthy plate model Malaysia. And I would like to educate patient, explain to the patient on the importance why high fiber diet is important to improve lipid profile, weight reduction, and also to maintain adequate nutrients intake. And the last one, I would like to suggest patient to do daily regular physical activity of moderate intensity such as jogging or brisk walking at least 150 minutes per week or 30 minutes in a day. For the monitoring and evaluation, I would like to monitor the patient body weight, the laboratory values such as renal profile, food blood count, and lipid profile, and compliance to the dietary advice, and lastly the physical activity level. For the discussion, CKD and ESRF patient has higher risk of malnutrition because more nutrients is removed and protein is breakdown during the treatment or the dialysis. And patient on CAPD need higher protein requirement compared to patient on HD because they are more prone to protein malnutrition, as protein losses from the peritoneal dialysis is more compared to the protein loss in the HD. And it has been shown that dialysis patient with BMI more than 25 kg per meter squared had higher survival rates compared to the patient with lower than 18.5 kg per meter squared, which is considered underweight. And patients with CKD are high risk of cardiovascular morbidity and mortality. So based on the MNT guidelines for CKD, managing lipid abnormalities by lipid lowering diet can improve the effectiveness in dialysis patient. Okay, and the findings from a current study implement that healthy eating, weight reduction, improved blood pressure, lipid levels, and increasing physical activity can contribute to delay CKD progression and remaining stable over 10-year interval. and also in the prevalence of type 2 DM and obesity. Next, high fiber diets promote the growth of short chain fatty acid producing bacteria in the intestine and demonstrated in clinical studies to be effective in treating the metabolic syndrome, obesity and CKD also. And low salt diet will increase thirst in patient and complicates food control based on the MNT. And according to the CPG 2018 on the management of chronic kidney disease, CKD patients should restrict sodium intake to less than 2,400 mg per day, which is same as 1 teaspoon of table salt per day. And then renal anemia is a common complication of CKD due to the reduced erythropoietin production by the kidney and also reduced iron absorption. So vitamins such as folate and vitamin B12, which can be found in the deep sea fish such as tuna, mackerels and eggs, are needed for adequate response for erythropoiesis. And omega-3 rich in food, based on the current study, also a good dietary intervention for SLE patient as it reduces the inflammation, it and the disease activity and also endothelial dysfunction and also reduce the oxidative stress. And next is vitamin C also may be benefit to increase the absorption of the iron. Okay, so this is my references. Thank you.